All right, everybody, welcome to Samaritan's Purse International Health Forum. Just a pleasure to have you guys join us today. Honestly, while during this pandemic, certainly I wish I could be traveling, but so grateful to have this technology available to us to be able to broadcast and just strengthen our knowledge of international medicine and being able to serve others. Just want to remind you before we get started today, the chat box to your right, just encourage you before we get started, if you will, just sign your name and perhaps where you're located in the world so that we may have that information. And also just at the end, we'll have a dedication of Q&A. So please raise your questions to us and we'd be happy to address those to the end. Before we get started, I'd just like to open up in a word of prayer. So let's bow our heads. Dearest Heavenly Father, we just want to thank you for this, again, this opportunity to join together at Samaritan's Purse International Health Forum. Just thank you so much for Dr. Jansen, Lord, just to be with us, to dedicate this time to improve our understanding of healthcare systems. And Lord, we just pray that you speak through him and just may we have open eyes and ears just to be receptive to what he has to share today. In Christ's name we pray, amen. Well, Perry, just a pleasure to have you here today. Dr. Jansen is going to be speaking to us about strengthening systems through strategy and collaboration. Before he gets started, just a little background on Dr. Jansen. He's a family physician who has served for many years as an SIM missionary, particularly in Malawi for 16 years. He's also happens to be the founder of Partners in Hope, which is a Malawian NGO that has become really a major partner with USAID, as well as Malawi's Ministry of Health, for strengthening both HIV and TB care throughout the country of Malawi. Since his return to the United States in 2016, Dr. Jansen has furthered his education. He received a master's in public health and has been working with Medsend and now AMH, African Mission Healthcare, which is an outstanding organization that Samaritan's Purse collaborates with, and I'm delighted to say that. And AMH has really worked in programs to strengthen mission hospitals to become really quality teaching hospitals. So without further ado, Dr. Jansen, thank you for speaking today about strengthening systems through strategy and collaboration.
Thank you, Lance. I really appreciate the opportunity to be here and actually the opportunity to find out about this forum. Somehow I had missed this. And as I was preparing for it, I went through your archive of webinars in the past and just some amazing resources that are there, and a bit intimidating with some of the speakers that you've had. My presentation today, maybe a little less academic than some of the presentations. I think it sort of represents, hopefully, in with health system strengthening, as I talk about my shift from doing patient care to focusing on health systems, which many missionaries have really less interest in, and also kind of from doing to coaching to kind of supporting people who are doing healthcare. My journey started a little over 20 years ago as I was getting frustrated with American medicine and really feeling God's calling to serve the Lord with my medical skills. I had learned about an opportunity in Malawi and was struggling to figure out how I would possibly do that as a missionary. I had a lot of educational debt, and I heard about what was then called Project Medsend, and they, by their policies, had to connect me with a sending organization. So I joined SIM, really in a sense to qualify for a loan repayment, but it was really the Lord's hand to put us with a very mature, very supportive mission sending organization that we really leaned on heavily during tumultuous times and times that the Lord called us to expand our ministry. And so they've been a really partner with us. And I had prepared academically and I think intellectually for going to Malawi, which is one of the poorest countries in the world at the time, and still is, and also had one of the highest HIV rates in the world. And I think we all remember in the early 2000s, that the HIV death rates, HIV was just decimating most of sub-Saharan Africa. And as I went there, I about 60% of the patients I saw that came in to see me came in with undiagnosed HIV-related illnesses. And I often say I was prepared for the academics of it, but I really wasn't prepared for the emotional impact that it would have on me taking care of all these HIV patients and really having very little to offer them. And I remember early in my time there, when I would have a day full of HIV, I would come home really just wiped out, basically giving death sentences to people through the day. And then it began to shift where actually I really had a sense of joy that I was being able to address these issues, make the diagnosis, sometimes not make the diagnosis when people weren't seemingly ready to hear it. And I remember one time I was driving home from work and a song on the radio was playing. It was called "What Breaks Your Heart?" And I was realizing, and I just love this song, you can look it up, but it was asking God to have what breaks his heart break my heart. And I was realizing that my heart was really getting bound to caring for people living with HIV. At the same time, I had the opportunity to be involved nationally with the Ministry of Health and UN and US government in strategizing how we could have a better response as a country, Malawi meaning Malawi, to HIV, and how we could maybe even start doing the antiretroviral therapy that was helping so many people in the West. And this really led me to starting a nonprofit organization and then a hospital focused on the HIV/AIDS epidemic. As Lance said, we founded with the help of Ministry of Partners in, which is a center that's actually a general medical center with a free specialty HIV clinic. Our first donors for buying this building and getting it open were all basically churches and my individual supporters. Our second major donor was the Ministry of Health, because I had been involved so deeply with the strategy and they knew what I was doing with very little resources. When it came time for them to get resources, and that time was mainly the Global Fund, we were sort of first to the buffet line when the resources came in, and received a lot of support from the government of Malawi. Ended up actually partnering with UCLA, which is one of my alumni, and their global health program. They put a rotation through this expanded laboratory. And then eventually we shifted from giving really excellent HIV care to being recognized by the Ministry of Health and USAID as a center for doing training in HIV. And then the grants increased to doing capacity building really throughout the country. And as I left there 4 years ago, we were working in 9 of the 26 districts in Malawi with I think it was about 114 different facilities doing capacity building for HIV treatment, prevent child transmission, and estimated that our program was directly and indirectly impacting about 300,000 people living with HIV/AIDS, which was so far beyond what I had pictured when the Lord called us to start this. One of the things I'm most excited about this whole journey was the ability to sort of realize one of our initial dreams and strategy points to have Partners in Hope really be truly a national organization, a Malawian organization. We never did establish a US board, for fundraising or anything. We established a very strong Malawian board. And when I left, we transitioned to Malawian leadership in all of the key positions. And I'm really proud of Dr. Agnes Moses, who our board recruited, really a lady full of God's spirit and a heart for serving women and for the poor. Alongside her is Ethel Namalima, who is our Chief Operations Officer. So these two women are the top women in this organization. And I think it represents what I want to see in Africa is women leadership. Not that I have anything against men, but it's women that I've seen have had such a huge impact on health systems. Alongside her is a whole different team of doctors and leaders, including a new addition, Dr. Peary, Sam Peary, who's on the right bottom, who is actually a very well-respected researcher as well as HIV clinician. You can go to the next slide. Oh, I'm sorry, I'm advancing my slide. Yeah, go forward 3 or 4 slides, sorry. I'm advancing my slides, but forgetting to tell you to advance yours. So here I am. There's Partners in Hope, our center. Go on to the next slide. And this is the team, Dr. Agnes Moses and her team. Next slide. As I came home from, actually we left Malawi largely because of family and health reasons. And I really couldn't see going back to American medicine. And my heart was really in Africa and increasingly focused on helping strengthen health systems. So I worked with Medsend while I was working on my MPH. And then I started working with someone that I had worked with in Malawi for several years, Dr. John Fielder, who left me in Malawi to really focus on African Mission Healthcare, which is a nonprofit organization that he and his friend Mark Gerson started. African Mission Healthcare is really committed to investing in mission hospitals, to strengthen mission hospitals, basically to serve those in greatest need. And that's our mission. The vision is really to see what we're calling enduring and improving health systems that are able to offer access to quality healthcare. And so our focus isn't just on an individual hospital or an individual missionary or an individual disease, but really on strengthening the health system. And that was what was so appealing to me. So far, we've worked with 43 partners in 18 countries and actually have distributed about $30 million in investment in these countries. You can go to the next slide. These are the co-founders. Dr. Fielder is in the foreground there. He's an internal medicine doctor from Johns Hopkins, really brilliant. Also has a really good mind for strategy. Next to him is Mark Gerson, who was a college roommate of John when he was in college, a really devout Jewish couple, he and his wife, Erica. His wife is actually a rabbi, Jewish rabbi, and they've been investing in John's projects really from the beginning, and they've seen how well he places his resources and that he has such a good return on investment. And the Gersons have recognized that Christian mission hospitals are having a huge impact, and especially on a per dollar spent. And they've increased their commitment over the years, including what they sponsor is the L'Chaim initiative. L'Chaim is Hebrew for to life. And it started out with the L'Chaim Prize in several years ago, $1 prize to basically to honor outstanding Christian missionary service. And starting last year, they've donated 2 prizes so far, and a third coming up next year for a $2.5 million investment to really bring some of these really good mission hospitals up to the point of becoming teaching hospitals. Go to the next slide. So the L'Chaim Prize has had 4 winners so far. And this $500,000 prize not only accomplished the things that they wanted it to accomplish in Burundi, Kenya, Liberia, and Sudan, but actually became a catalyst for other partners coming along with resources and in-kind gifts to really have a dramatic effect on boosting the capacity of these hospitals. All of these you could see are white male missionaries. And one of the things I got permission to announce that you guys are hearing before just about anyone else, not Lance. Lance knew because he was on our committee to help select the 2020 prize winner. And you can go to the next slide. The 2020 prize winner, for the first time, we're actually honoring an African national health leader. Dr. Priscilla Businge is an OBGYN working with the Banja Teresa, which is like the Sisters of Teresa. Catholic mission in Uganda. And she's going to use these resources to expand a center that they already have for doing deliveries, repair of obstetrical fistulas, and this will dramatically increase their capacity to do C-sections and do more obstetrics, as well as obstetrical fistulas, which is something that she specializes in. So I'm very pleased that it's a national, and even more pleased that it's a woman. And so you're the first to hear of that prize. You can go on to the next slide. Her first initial sites for investing in the Mission Hospital Teaching Network in Malawi, at Nkum, and at Kibuye at Kibuye Hope Hospital. And this is a 10-year investment where we're helping strengthen the hospital, their infrastructure and housing, and moving them towards what they need to become really a center of excellence for teaching. Go on to the next slide. So that's the background. Now on to talking about health systems. I decided actually both to make another announcement and use this as a framework for talking about health systems. I think a lot of you who are mission-minded people may have taken the Perspectives course, Perspectives on the World Missionary Movement. I did before come together. I've been part of the committee as well to produce what we're calling Outlook on the Christian Global Health Movement. And this is basically, we can't call it Perspectives, but it's basically a perspectives for healthcare missions. And we hope that it's going to be out in the next several months. It is going to start out as an online course, and hopefully will then expand to being a certificate course and maybe even a diploma or even master's level course as the curriculum gets more robust. Go on to the next slide. So you may remember that they use four major areas that they cover as themes. One is the theology around mission, history of mission, cross-cultural issues around mission, and then strategy. And so this book will use the same. Go on to the next slide. I'm not going to go over all of these because you need to take the course. But in the theology, they really talk a lot about the theology of health and suffering and death and disease, and then have a very strong emphasis on the concept of shalom. Shalom, we know is a Hebrew word, and we often use it as a synonym of peace, but it's really a much deeper word than just peace. It really, my definition I like the best is that it represents a right relationship with God, with self, with mankind, our neighbors, both our church and the unreached, and then with all of creation, and includes a concept of kind of planetary care in a godly way. Next slide. The next area is history, and it's some really great historians, including Udeman, who wrote the book Sent to Heal, and I'm learning a lot about church history from these guys. But basically all the way from Christ through the early disciples and the early church responding to epidemics. Real emphasis then on the transformation that basically modern medicine brought to the missions movement. And I think a lot of us know this history, that there were a lot of unreached areas that were hostile towards people of faith until you could meet some of their needs, like healthcare and surgery. And so it was really, healthcare mission has been the tip of the spear to get to places that were otherwise not receptive to the gospel. We also know from this history, they emphasize really the tremendous impact that healthcare missionaries and mission experiences had in shaping the global thinking and even policies around public health and community-based care. Really great story of early meetings in Tübingen, Germany, that led to the establishment of the Christian Medical Commission, that has a huge input into what's called the Alma Ata Declaration, that really was one of the first to identify health as a right, and then also the importance of primary health care and community-based care. And it really shaped a lot of the good work that's happened in primary health care. Next slide. More recently, Go back one. Yeah. There you go. More recently has been actually some developments that we know about, you know about and have spoken about, is advancements in health education, Pan-African Academy of Christian Surgeons, and then more recently the Christian Association of African Physicians, that's more focused on primary care. Alongside that has been the Samaritan's Purse post residency fellowship has been a huge boost to medical education. There's been an increased interest in engaging health systems. And really over the last 50 years especially, there's been an indigenization, a nationalization of a strengthening of church-based healthcare organizations. And some of these are really strong, some are weak. Some hospitals, when they got nationalized, collapsed because they weren't done right, and some have thrived. We've also seen in our current situation that healthcare is still one of the fields that can get people onto fields that there's no other access to. So there may be a country that would even recognize a kind of a business as mission or English as a second language as being too threatening to them, but many of them have such strong health needs that they'll welcome Western missionaries in. It's a great strategic front line for a lot of the unreached and unengaged people groups in the world. Next slide. Culture obviously is a huge part of working cross-culturally. The culture area talks a lot about biblical worldviews and subcultures with a real strong emphasis on cultural humility. And I think a lot of us are familiar with cultural intelligence, where well, in this culture, this particular hand signal means something different, or they're offended if you look at them in the eye. So learning the specifics about another culture helps you interact well with them and avoid making mistakes. What cultural humility is really understanding that the way that we see reality and the world and situations is also shaped by our experiences and our culture and our education, and recognizing that, being humble to say, well, I don't understand this and it looks like a mess to me, but our national person sees this more clearly than I do because this is their culture. And I really love that part of this course. Next, strategy. I'm a strategy person, so I got put in this group. I could go on and on about this, but it's really a revisiting of the strategy behind the history, in a sense that initially that healthcare missions got us into the interior. We built mission hospitals and healthcare systems. We influenced primary care and public health. Huge impact in responding to disasters, as I've talked about. And the strategy behind how those help, not only with planting churches and strengthening the spiritual aspect, but also really having an impact on the health of the country. Definitely, we've seen over the last 50 years in particular, some real amazing tools in understanding organizations, organizational dynamics, learning about asset-based development rather than just sort of needs-based development where we just throw money at things. We still do that more often than we should. We've learned about participatory planning rather than us sitting here and figuring out what's good for them. We go alongside them and do co-create and think about things together. My particular area that I'm interested in right now is systems thinking, which is really understanding the complexity of many of these sites that we go to. You can go on to the next slide. If we think about complexity within healthcare, we have simple things. I used to like cleaning out earwax. That's the left picture, because people come in, I can't hear out of my left ear, and a few squirts with a syringe, and they go, and you're their savior because now they can hear. That's a simple thing. Complicated, doing laparoscopic surgery is complicated and requires a lot of skill, but there's only a certain parameter of things that can go wrong, and it's another level of complexity, but not something like Ebola in West Africa, as Samaritan's Purse knows better than most people. That's a complex situation where you have so many things happening at once, and the efforts that you do actually have the opposite effect of what you want. And so, and then chaos, and SP is familiar with chaos, war zones as well, where there's basically no rules. Everything is just chaotic. Most of what we do in healthcare missions, I would say, fits into complexity. And you can go to the next slide. And I would consider these to be what we call complex adaptive systems. That means that there's all these things that are interacting on one another, and it's very unpredictable where it's going to go. This is just a list. I won't go through this on what are some of the properties of complexity, but most of what work, sometimes the donors want you, and I value results-based management and sort of that flow from input to activities and output, outcomes and impact. But generally, most of the things that happen don't happen any kind of linear way. There's all kinds of things that interact. Some things that you couldn't have anticipated that turned out to be very critical in success. Some things that actually completely undid all of your plans. And that's really what we're dealing with when we're talking about health systems. Go on to the next slide. So in systems thinking, we're really wanting to identify the root causes that are leading to disease so that we can improve health. But next slide, really there's a whole bunch of factors. And these are just some that I quickly threw up that are involved in basically getting from root causes to improved health. Next slide. And then all of these are interacting with one another. And this is a simple version of complexity theory. I could talk, sometimes I talk too much about it and my wife's eyes glaze over. So I won't inflict that upon you. If you're interested in complexity theory and systems thinking, there's lots to read, and contact me and we can nerd out together. But I won't inflict that upon you today. But it's basically just to have that understanding that really these are very complicated systems. And if we want to have an impact on a particular disease or on a certain people group, we need to think more broadly about the systems. We'll go back to the vision statement. Next slide. AMH's vision statement really emphasizes developing enduring and improving health systems with the goal of access and quality compassionate care. So it's that journey. How do we create that system that leads to that outcome? It takes more than just sending missionaries or building a building or funding a program. It really takes a deep understanding of the strategy behind it, and then strategic investments to help these. Our goal is really to help mature these health systems so that they actually become able to grow and adapt as they should. Go on to the next slide. This, I won't go into depth on this, but this is just sort of this process. If we think of an individual Christian or a national church as an analogy for a health system, we have stages that we go through, that they go through, or that we've also gone through, and these are stages we should be applying to our work in developing countries as well. And each country and each region and each hospital will be at a different place in this journey, but it should be moving from initially learning about Christ and salvation to developing practices and being in fellowship to serving. And then the outcome also, as we are more mature, we think outside of our own little sphere to being outreach oriented, to being Great Commission oriented. And one of the things I'm really excited about, we're seeing it happen in PACS and other things, we're developing, say, a Congolese doctor who goes to Gabon to train as a surgeon, and then could go into Chad or South Sudan or places where we could not send a Western missionary, but they can go and thrive and be more impactful. So we want to see that journey with these hospitals to become not just places where they come work alongside a missionary, but places that they're leading and that where God is sending them out. Go on to the next slide. I had the opportunity to do what I would call a critical analysis for my master's program, and I chose the model of India because India is sort of a natural experience. They had a forced indigenization during the time of independence. And I wanted to learn, and then we know actually from India that there's some amazing hospitals and training hospitals that survived this and now are thriving. We think of Vellore. CMC Vellore is one of the most prestigious training centers in all of Asia. It's a Christian health center that's still focused on serving the poor. I'm sure it's not, I've never been there, but it's not a perfect health center, but it has thrived despite that when others have collapsed. And so I dug through hundreds of articles and biographies and tried to come up with some themes of the ones that really did become successful. What were they doing? I couldn't really find enough information on those that failed because unfortunately we don't write as much about our failures as we do our successes. But I did find probably the most important one was the creation and the transmission of a shared mission and vision. And that included a very strong heart for serving the poor. Almost all of these, actually, not almost all of them had an early emphasis on education, on medical education, and especially for women who, in addition to the low caste people, women often didn't have access to education. And places like, there's a case presentation on Ida Scudder that you should read, a wonderful missionary kid who became a missionary doctor and established CMC, what's now CMC Vellore. Strong emphasis on women, really fostering local ownership and even champions. And actually a lot of these hospitals had very high level Indians who were donating to them, who were supporting them. There's a picture of Mahatma Gandhi visiting CMC Vellore. It wasn't just that they had a real strong church somewhere in the US that was sending them money. They had strong local support, a strong relationship with their community, good business models, and strategic collaborations. We know that the remnants of that, or the result of that is really amazing organizations like the Emmanuel Hospital Association and the CMC Christian CMDA of India. Lastly, building good facilities. Having good facilities attracts people and improves sustainability. So that was an enjoyable study for me, and I hopefully will be helpful as we think through. To the next slide. And what I see really coming down, what I see happening within medical missions, and I'm not talking necessarily about medical missions as us going to them, but more broadly what God is doing through Christian healthcare. We see a greater shift basically from European and what we would consider Western countries like the US sending people to now the global South becoming a large sending countries. The church in South Korea sends a huge proportion of the world's missionaries. So we're seeing a rise in the global South as sending organizations. We are also seeing this transition of mission hospitals to indigenous Christian hospitals. And as I said, we can, maybe all of us think of some examples where it went well and where it didn't. Some become basically private hospitals. Like we have a lot of our best hospitals in the US were started out as Christian hospitals, and now they're expensive high-tech centers that have no faith component. The medical education, and God is using this to get places where no one else can get, open doors into unreached people groups. Great expansion of medical education, developing of local leadership. Certainly Zoom and other technologies are happening that allow us to actually be more connected and get them resources. And I am definitely seeing an increased sense of collaboration. Go on to the next slide. I'm almost out of time, but I won't go into this, but I just want to sort of reflect on the importance that Christianity and healthcare mission has had on so much of what we see in the world. From medicine and science to human rights and civil rights and political science. What I really want to see is that the Christian voice, the Christian work, Judeo view, especially over service for the poor and filling in the gaps, is actually transformational for our culture. We see a lot of people coming from doing relief as a humanitarian effort, and they actually consider faith to be something that shouldn't be a part of it. And we need to be there reminding them how important not just the Judeo-Christian ethic is, but the power of God to transform people and transform nations is. So we have to be involved. We have to continue to be involved. We are the salt of the earth. We're the light. And we shouldn't be we shouldn't be hiding our light. I think I've talked to people who work for foreign government organizations, NGOs, and they say, I don't think the church is doing anything. It's like, well, clearly you're not looking, because the church is doing a lot. And we need to let them see this. And we've had actually, but from the time of Bush, really unprecedented access to not just resources, but the attention of our government. Foreign governments often also recognize the importance of faith-based organizations and churches. So we actually do this better when we're united. And I know united is a whole in our country, but in the church, we should recognize that a united effort to really exemplify Christ's heart for unreached people and unmet needs. We can continue to be a light to the world, even if we don't get the money, but it can be a source of revenue, but we're called really to be light to the rest of the world. What I'm seeing is, you can go to the next slide. What I'm seeing is an increased interest amongst many organizations, including Samaritan's Purse and CMDA and others, at recognizing what others are doing and explore and do things more collaboratively. There's been talk, actually, just in the last year or so, CMDA, Health for All Nations, Medsend, CCIH, AMH, we're talking about even the people using the same term, an institute, and for a healthcare mission. And I think I don't necessarily advocate there being some building or some ownership of a specific entity, but I see people coming together to share knowledge, work more collaboratively, and come together to have impact that would be greater than any of us could accomplish alone. These are some thoughts that I've been putting together with some of these other organizations like CCIH, who has their 30 by 30 initiative, Medsend and CMDA, to create an institute that allows us to come together on accessing resources, doing training, sharing knowledge, supporting management, having expert panels, doing collaborative research and advocacy. And I think the more that we come together, the greater our impact will be. It's sort of the effect of pooled resources, and I think will help us be more effective. So that, if you have any questions and you'd want to be more involved in exploring how to be a part of that as an expert panel, or how your organization might be more engaged, feel free to reach out to me. You can go through Lance and the people at World Medical Missions as well. So I'll close at that and leave some time for questions. I think I'm not hearing you, Lance.
Yeah. Hey, Perry, thank you so much for an amazing presentation. That was fabulous. I hope we have a number of questions. I certainly have some comments while I'm waiting for those to appear, but I just wanted to start off by saying thank you to your wife for allowing you to nerd out about healthcare systems. You're amazingly analytical about it, and really just I think you bring up some really incredible points, nuanced points about developing healthcare systems in the developing world, and I really appreciate what you've said today. And one of the things I wanted to point out, and actually you almost you really beat me to the punch here, but I just really was so excited when I saw, some of the people attending today virtually, representing so many organizations, amazing organizations. And I hope I'm going to name a few people. I hope they don't care if I call them out. But I think what's happening, Perry, and is so exciting to me, is there are so many organizations now like AMH, African Mission Healthcare. You guys have amazing people on your team. CCIH, I see Mona Bormet's out there today. Bruce Steffi's with PAX. You mentioned CMDA, and we could go on and on. There's so many great organizations, and I think they all bring a lot of resources to the table. There's really, I think, just developing an amazing international network of capacity, through faith-based organizations, and we have opportunity to work together like we never have before. So it's an exciting time to be in missions. So with that, let me just go ahead and bring a few questions to the table. My good friend Jesh Thiessen from British Columbia says, what is your view on the evolution of the relationship between mission hospitals and national government healthcare? And then he references Divey 1949.
Okay.
Yeah.
I'm not sure what Divey 1949 means.
I'm sorry, that's someone else. I apologize.
Oh, okay.
Yeah, just the question.
Yeah.
What is? Yeah.
Well, I mean, I think there's 100 stories depending on which country you look at. I mean, there are some countries that really recognize the importance of important role that healthcare missions plays. Some themes that are there that I think we see in many countries is that healthcare missions, when the national health system is struggling, with a strike or with, a strike is probably the one that we can think of the most. We think of Kenya. All of the healthcare workers go on strike because they don't like their terms. And it shifts this huge burden onto the mission hospitals who basically, their ethics require that they take care of people. But at the same time, when the money is tight, sometimes the money doesn't flow, even with written agreements from the government to the mission hospital. And I know that in service level agreements where you're supposed to give money for every delivery, every child care visit and stuff, but often when the money is tight, and the money is always tight in these developing countries, they feed their children first, so that the government hospitals get money. If there's anything left over, they'll try to honor the commitments that they've made to the Ministry of Health. And so it really creates a lot of burden on the hospital to be able to provide high quality care and be sustainable and serve the poor. And so, there are opportunities to develop sort of business strategies where you services that to help with that. One of the strategies we adopted at Partners in Hope, just almost by accident, was we became an NGO doing work, and a lot of the overhead stuff that came from our grants helped to run not just the administration, but even the hospital itself. The key thing is really looking for business opportunities to improve your income without sacrificing your core mission, which should be really to care for the poor and care for the sick, or should include that, I should say. So, I think governments really depend on the mission hospital, don't always support them.
Okay. Thank you so much, Perry. Matt Larson says, what are other ways to boost collaboration beyond the panels and the joint research previously mentioned?
Yeah, I think it's almost like the more ways, the better. There should be 100 ways. The key thing is, part of it is actually mapping out and trying to understand who's doing what where, and making those deliberate connections. One of my pet projects that I'm still trying to find both money and time for would be a Wikipedia approach to sharing knowledge, and where basically African healthcare providers, people from Asia, give input into how to run the hospital and how to do care better.
Mhm.
The key thing, though, I think, is really developing relationships and trying your best to not think of your universe as the only universe, but to recognize that we are all a part of a larger system. And the more interconnections that we have, the better that this will run.
Mm.
There's a great article on from Jeffrey Braithwaite looking at health system interventions that worked, and there were some principles using systems thinking, some principles behind that. I'd be happy to share that article. But one of them is making making lots of connections. Failing fast, as a term that we use often in AMH, is really making lots of attempts and testing out, having feedback loops that help you respond. If you have other ideas, Matt, on better ways to collaborate, I think part of it is sharing those ideas and holding that value to say we need to collaborate. We might have different opinions about dunking or sprinkling or theological issues, but we really are all part of God's hand reaching out with the gospel, and also with a cup of cold water and providing health care.
Mhm. Thank you so much, Perry. Let's see. Arista says, how do you manage the brain drain, and do you have suggestions for managing that?
Yeah, I mean, brain drain is a real problem, as we know. I think there's some things to try not to do. I think we tend to say, well, wouldn't it be nice if Dr. So-and-so could come over to my hospital and train, and then we'll send him back there. And there's really so many risks to doing that. But even more importantly than that, we're not really focusing on building the capacity of that country to be able to not just train that person, but have a place for them to practice. So
Yeah.
if you bring them back to, Michigan, and you teach them how to do all these things, and you send them into the bush, they don't have anything that they need to do, train to do. Well, better just to stay here. Really, what we should do is building up the hospitals as well as the national faculty. PACS has one hospital, Latane Hospital, that's currently being run all by PACS graduates. There's not a single, expatriate missionary faculty. And so our investment really should be building the national institutions, training the national leaders, trusting the national leaders. That's why I'm so happy about the L'Chaim Prize. Not only have we recognized a national leader, we're giving her $500,000 to do what God's calling her to do. Rather than say, I'm going to fund some NGO to go in and help her do what she wants to do. We're trusting our national colleagues, and we're coming alongside their vision and not imposing our own vision.
Yeah, Perry, that I couldn't agree with you more. I love what you said in your talk about participatory planning, and how we're being a lot less paternalistic and a lot more collaborative with our African brothers and sisters, and that's where real development takes place. So that's awesome. I love the L'Chaim Award that it's going to female Ugandan this year. I couldn't agree with you more.
Mm-hmm.
Your friend Mona Bormet from CCIH says, Perry, always happy to nerd out with you. You mentioned the need to partner to improve income without sacrificing core missions. I have found in interactions with organizations and with individual health facilities that they focus a lot on service delivery, but not on communications, telling the story to attract partners. Do you have any examples of simple modes of communication that have helped faith-based organizations draw good attention to their work and mission?
Some. It's definitely a space that needs a lot more improvement, and sort of having been there myself, when you're really busy caring for people, and a lot of, actually, I was in the capital city, but a lot of these people are in rural settings where they don't even have good internet, and they're really overworked, and so it's very hard to get them to sit down and write an email. One of the ways that we can do it is by taking that burden off of them and ourselves investing in sending people to capture those stories in a way that requires very little of them. And so we've done this in a couple of instances where we've sent a videographer for a couple of days and a biographer to go there, just gather some stories and tell the story. And so taking that burden off of them, where it's basically they can spend an hour and you get a whole bunch of material from that to tell their story, not in an exploitative way, but in a way of just highlighting it, highlighting what they're doing. So anything that can decrease the burden on them. There are increasingly simple systems using mobile technology, and so developing apps where they can quickly take a picture and send it is helping. There's some apps that are doing that where you're connecting your giving directly with the person who's donating, seeing the impact of their donation almost in real time. That's helpful. It can also cause you to focus on the wrong things.
Right. Awesome. Perry, I don't see any other questions right this second. With that, I love what you said. As we continue to collaborate and we build systems and infrastructure together, let us not forget the main thing. Keep the main thing the main thing. And you referenced light. And so I thought I would conclude with Isaiah 63. It says, nations will come to your light, and kings to the brightness of your dawn. So let us not forget in our efforts to build infrastructure and develop these bridges that we keep Christ the light in the efforts that we put forth. So yeah, Perry, thank you so much. That was so no pun intended, so enlightening. It was really informative about the healthcare systems. And I think I'm glad to say I really am optimistic. I think we are making progress, and we need to not grow weary in the work that we do together. So let me just draw some quick conclusions. Let me just say, remember, CME credit is available for this session. The form and instructions will be available in the email, and we'll be sending a follow-up email with the link to this recording. And please, I just encourage you, as we mentioned these organizations, this webinar, Samaritan's Purse International Health Forum, if you go to the archives, there's so many great presentations like Perry's today that should serve as a great resource to you and your organization. So please reference those. You can still get CME credit with listening to the recordings and answering the 5 questions. So really encourage you to do that. Next, if you haven't, please join Samaritan's Purse International Health Forum. And that's at health.samaritanspurse.org. Join us next month. It'll be Tuesday, December the 8th. Eric Kramer will be speaking to us. It says, where there are no narcotics, opioid-free anesthesia. Eric is a CRNA that's served many years with our partner hospital, Tarahumara Hospital in Mexico. He's also served on our DART and disaster response. So be sure and tune in with us next month, December the 8th, to hear that. And with that, again, Perry, thank you so much. You guys have a great day. God bless.
Thank you.